All right, well, our last session we're equally excited about because this is a discussion and a presentation on the intersection of women's health, living with IH, and the mental health impact that those two things have. So it's my pleasure to introduce Anna Smitherman. She is a clinical psychologist living with idiopathic hypersomnia. Anna graduated with her PhD from the University of Alabama in 2014, which was pre-diagnosis with a specialization in health psychology. She has worked for over 10 years with patients diagnosed with a diverse range of health concerns, including sleep disorders. It was her professional expertise which enabled her to recognize her own symptoms and advocate for her assessment and diagnosis of OSA in 2016 at the age of 30 and of course, idiopathic hypersomnia at the age 38. She has spent the last few years working and finding out the best way to balance professional life while chasing after her two young children and finding the best ways to manage her IH. She's excited to finally have a few more spoons to share with all of us and to be able to be more involved with the patient advocacy side of her life and the Hypersomnia Foundation. And her presentation is a really cool title. She says, I don't have time for this, women and the interplay between hypersomnia, mental health, and modern life. Thanks, Anna.
Hi, thank you for having me. As you said, I have professional experience in dealing with lots of chronic conditions. And in all of that time that I was working with people in coping with and managing those, had no idea I was dealing with my own. So I'm excited to be able to be more involved with the Hypersomnia Foundation and to be able to talk with you today. My talk is kind of a blend between lived experience and what I know about, psychology and chronic conditions and things like that. So yeah, I'll jump in and I can share more about my own journey if needed. Before I start, I do want to say a lot of the things that I'm going to be bringing up, I know lots of people with chronic conditions and with hypersomnia conditions experience these things. I'm not trying to say that only women experience them, but there are some unique factors that contribute to the way women experience these kinds of challenges. So please, we all have more in common than we do different between us. But for the sake of this conversation, it may sound like some generalizations. So I chose the title, I Don't Have Time for This, because I think that most of us in our culture today feel rushed and like we don't have enough hours in the day to do all of the things that have to be done. And that's with, generally healthy people, much less folks who are dealing with additional challenges like those of us with hypersomnia. So to figure out what this interplay between hypersomnia, mental health, being a woman is, this is what we would call intersectionality. We don't have enough research and data on women with IH and mental health factors to be able to focus only on that. So we have to look at chronic conditions as a whole as well to be able to deduce what are some of these extra challenges that might be there, form some new hypotheses about what this specific population might be challenged by. So we're going to spend some time talking a little bit about women and chronic illness and mental health, the role of reproductive health. So lots of women's health is related to reproductive cycles and the way that changes throughout a month, throughout the life, all of the above. We'll also spend a little bit of time talking about women in society and some unique challenges that women face, and then we can hypothesize or discuss the ways in which hypersomnia adds to that and how that affects mental health outcomes. We'll go over some treatment challenges and a whole mess of variables because that's what we're dealing with right now. And we'll try to make as much sense of it all as possible. Let's see. All right. So we know that idiopathic hypersomnia does not have a clear cut, yes, we can all agree this is the prevalence. So if we can't even get just the 100% we can all agree this is the prevalence, then we can't really say for certain if there are higher prevalence in women or men. There's been some studies that have suggested it might be a little bit higher in women. There have been others that say it's about equal. We know that in narcolepsy, that more men experience it, but there's more research in that area rather than IH. So we really can't say. But we do know that women tend to be underdiagnosed for a lot of different things. So there's a likelihood that there's a general lack of accurate diagnosis with IH, but that women may be even more so affected by that lack of diagnosis. With chronic illness in general, women are more likely to experience chronic non-fatal conditions that lead to illness and disability. So to put that in contrast, men are more likely to acquire chronic illnesses that have a higher rate of mortality. So the kinds of illnesses that men tend to get are essentially more likely to end their lives. You know, we're looking at lots of cardiac factors. There's been a lot of research lately about like COVID and post-COVID issues leading to mortality with men. Women tend to get chronic illnesses that won't kill you. They'll just make things really hard for the longer life that you have. So more distress, more stress. Those types of things include musculoskeletal disorders, back pain, mental health issues like depression, anxiety, which are also considered chronic conditions, Alzheimer's disease and other dementias, headache disorders, things like that. Let's see, I have my little chat here in my way. So mental health conditions, as I mentioned, while they can be kind of sequelae of chronic medical conditions, they are considered chronic conditions on their own, and they disproportionately affect women globally. So let's see. In fact, health loss that was caused by depressive disorders was over a third higher among women than men globally. And that was as recent as 2021. So women are more likely to experience depression. And when they do, they have more health loss caused by those conditions. More recently, even in kind of popular media, there's been discussion about the fact that women are more likely to be diagnosed with autoimmune disorders. And there has been some interesting added variables to that to explain some of that, which is that women are more likely to suppress anger. And that anger suppression is at least in part contributing to the development of these autoimmune disorders. And so an autoimmune disorder is where the body's immune system essentially starts to attack its own cells. There are over 80 different known autoimmune disorders, narcolepsy being one of them. And so that emotional experience, those societal expectations and gender roles are quite literally making women sick. It's kind of an apt metaphor. You hold in your anger and it turns toward you and starts to affect your body. Let's see. One thing that's really important to keep in mind about women and chronic illness is that much of the data that we know about it needs to be taken with the understanding that there is generally insufficient funding for research and care for these conditions. So we need to know a lot more about these conditions and how they affect women and maybe why women are more likely to experience a number of them, but it's generally been overlooked. More recently, that has been changing, and then there's been some ups and downs in women's health research of late, but it does seem that in general, more attention is being paid to that, but there's a lot of ground to make up for. Okay. So we know that in regards to chronic medical conditions and mental health, having a chronic condition increases your risk of having a mental health problem. Particularly depression and anxiety are most common. We also know that having more than one chronic condition, or even more than that, accumulating multiple chronic health conditions, has a kind of dose response. So the more chronic medical conditions you have, the more risk you have for developing a mental health problem. And additionally, the more mental health conditions that you have, the higher risk of accumulating multiple chronic conditions is. Pardon me. So, for example, women with depression or anxiety are at increased risk of developing one or more chronic medical conditions. Being diagnosed with comorbid depression and anxiety increases that risk even more. And so you end up in this kind of vicious cycle where maybe there's one chronic condition, it leads to a mental health diagnosis, which adds your risk of developing more chronic conditions, which I know in the last talk, I thought it was a really important question that somebody asked about, what if you have IH and endometriosis, and the accommodations that are needed for that. And that is not an uncommon experience. Many people who have one chronic condition are likely to have more than one. And in that case, you're looking at mental health factors as an outcome of having chronic medical conditions, as well as mental health diagnoses being a chronic medical condition in and of itself. So there's this really important multi-directional relationship going on here between all of these. And we're not even looking at specific chronic conditions at this point. This is just chronic conditions as a whole. Okay. Oh, I'm zoomed in. How did that happen? Oh, no. Okay. So what we know is that more than 50% of people with IH experience psychiatric comorbidities. So people with IH in particular, so kind of going away from that general look at chronic conditions, people with IH have a very high risk of developing psychiatric comorbidities, particularly anxiety and depression, but other concerns as well. People with IH are also 3.7 times more likely to have a comorbid mental health diagnosis. So with IH, and I apologize, I'm kind of IH centric today, I think because of my own perspective, but so at least with IH, the likelihood that there will be some kind of mental health fallout from this experience is pretty high. And so we know that women more likely to have chronic conditions, regardless of whether or not women are more likely to have IH, which we can't really speak to, they're more likely to experience mental health outcomes as a part of that as well. So now let's talk a little bit more about the reproductive health and in IH and mental health. I feel like my presentation is getting a little wonky. I'm double checking something. So women go through multiple phases in life where there can be kind of a loss of control, a sense of identity disruption, a sense of not knowing oneself, um, with hormonal shifts and adjustments. And these come in the presentation of life periods as well as kind of acute life events. So as we move through a woman's life, we can look at all of these different areas and we can speculate the ways in which IH may, or hypersomnia in general, may actually interact with these periods more strongly. When we look at adolescence, we already know that teenagers need more sleep. Their sleep cycles tend to be delayed. They want to go to sleep later. They want to sleep longer. They're kind of learning their bodies as they're shifting through puberty and into late adolescence. And so it's hard to know oneself. There's all sorts of stigma about teenagers being lazy and just sleeping all day, and they're sleeping through class. And so while all of that is happening, that's also a common time when people start to experience the onset of hypersomnia. So it's very difficult to be able to suss that out. And oftentimes these symptoms can be dismissed and can be not only dismissed, but attributed to, poor discipline, character flaws in, the generation, those types of things. And so people who may genuinely be struggling and getting in trouble for falling asleep in class or being told that they're disrespectful, these challenges may be due to some other factor, but it's less likely to be caught during that time. Menstruation, the kind of monthly cycle that women go through, it comes along with fatigue, can come along with brain fog, can come along with mood alteration, can come along with insomnia that can actually still affect people with hypersomnia. So that shifts, and that goes through a big portion of a woman's life where every month they're experiencing shifts in their body, which can also affect the way they experience their hypersomnia symptoms. So that can exacerbate those symptoms, and maybe some of these accommodations that were discussed may be more needed during certain times of their cycle than others. And so it's not that there's a one size fits all for one person. It shifts throughout the month as well as throughout the lifespan. Contraception. There are always concerns with medications about whether or not they can affect hormonal contraception. And there are some medications that are used with hypersomnias that can interact with that. I have a section about complex medication issues later, but that's always a concern. And whether or not treating with certain medications will affect a woman's decision or a person's decision on what kind of contraception to use and how effective it will be, and what risks there might be involved. Pregnancy is another factor. If you think about a person who may be planning a pregnancy, you might think, okay, well, you just have to maybe not have your medication, because none of the medications are particularly recommended during pregnancy. And so a person would have to consider medication management during pregnancy. But also, if they're planning to not have any medication, people don't always get pregnant right away. So depending on how long they may be waiting for the actual pregnancy to take place, they may also be without medication. There may be kind of tracking a cycle. Can I use medication? I know I'm not going to get pregnant during these time periods. Can we track during this? And so lots of involvement of multiple care providers to manage that risk and make those decisions. And then you have to look at after pregnancy, where there, is continued concern about medication use if there's lactation, breastfeeding, and how that can or might not be transmitted to the baby. But then there's also this increased risk of mental health concerns, both perinatal and postpartum. So this is a period of greater risk. We know that people who have a history of any kind of depression or anxiety are at a greater risk of developing perinatal or postpartum depression and or anxiety. And so that layered with maybe not having your treatment managed as well as you previously had, not having access to the same resources, being kind of experiencing irregular sleep patterns that maybe you were able to manage and have good sleep hygiene and do things in certain ways that helped manage your symptoms. Being pregnant really throws that off. The only time I have ever experienced insomnia in my life was towards the end of pregnancy. I thought, well, at least I don't ever have to deal with that, because that sounds awful too. But pregnancy has a way of teaching you new things. And then, of course, with a newborn infant, sleep might not be bad. Maybe you are fortunate to have lucked out in that way. But for a lot of people, sleep is all over the place. And even with children who are considered good sleepers, the early months, you have to get up to feed and things like that. And so, whether or not people have partners who can be involved in that, choosing whether or not lactation or bottle feeding is something that you want to do or can do. Some people may decide that their parenting journey won't involve their own pregnancy, and that may be related to symptom management and what they feel like they can or want to sacrifice to move into that kind of new phase of their life. There's a relatively new term that is being used these days called matrescence. So this is like adolescence is kind of moving through puberty and into adulthood. Matrescence is the evolution moving into like a motherhood period of a person's life. And we're starting to pay more attention to this because this is a huge shift. There are changes in role expectations. There are also hormonal shifts during this time period. There are extra demands to where the things that maybe previously you would have done to manage symptoms and be high functioning in your job, you can no longer do because you also are working around your children's school schedule. You can't sleep on the same schedule as you previously would, even if they're older children and sleeping through the night, because you still have to get up and get them to the bus stop on time. Your symptoms don't necessarily take that into consideration. And so you're constantly having to adjust and find ways to get the job done. And many people are fortunate and have good partners who are able to support through that. Many people do not. And so these are challenges that are unique to that kind of period of time. Interestingly, given the delay to diagnosis for hypersomnias, a lot of people might be actually being diagnosed during this period of their lives. That certainly was the case for me. And I would say that anecdotally, the reason that I actually pursued treatment, because there was this kind of discussion with my sleep doctor. I was already connected because of my sleep apnea. And, they started suggesting that maybe it was this. And I said, I was pregnant, I'm breastfeeding. I can't think about, any of the medication options right now. And I honestly didn't really want to accept that might be what was going on. But then one day, my 4-year-old son and I, he was 4 at the time, came home and he wanted to play, and I said, okay, well, just give me a few minutes. I need to go rest for a little while, and then as soon as I wake up, I will come back and play with you. And his reaction was, no, mommy, you always sleep for so long. And that was the kind of inspiration I needed, the motivation I needed to take care of this health condition. Thinking about myself wasn't really a factor. I thought, well, I've trudged through this on my own for a few decades now. I can trudge through it some more. But during this time period of your life, you have other people that are depending on you. And sometimes their reflections of your life shine a new light onto it and help modify your decisions. There's also concerns related to sexual health, in that there are relationship dynamics at play, communication at play. Being sleepy is certainly going to affect desire, can be involved in arousal. The kind of easy thing that people rely on in their sex lives is you are together at bedtime, especially during a period of time where you're busy and working and have children. But by the time it's time to sleep, it's time to sleep for people with hypersomnia. And so you have to think about that. There are medications that you take before bedtime that have to be considered when you're making decisions about how you engage with your sexuality and with your partner. And, this can cause conflict if there's not a lot of understanding. It opens people up to conversations, though, that could actually enhance their connection with each other, and have conversations that, without added challenges like hypersomnia, might not ever happen. Because unfortunately, a lot of people don't talk about sex with the people they're having sex with. So that opens things up in some ways. We talked a little bit about multiple chronic conditions. Women are more likely to have multiple chronic medical conditions, but there are also a great deal that affect only women. So you're looking at endometriosis, polycystic ovarian syndrome. These are things that exacerbate some of the things we've already talked about: menstruation, contraception, pregnancy, but energy, cognition, thoughts about oneself, body image, that affects mental health. That added stress can exacerbate hypersomnia symptoms. So you're looking at all of these different factors and variables swirling around this one person who's also trying to go to work and keep up with young children and manage all of these things. And then after maybe you feel like you've kind of gotten a handle of that, perimenopause and menopause can show up. So, the kind of third cycle that women tend to go through. Perimenopause can start as early as age 35, although more commonly in the early 40s. It can last 10 to 12 years before menopause, which menopause is kind of the date in which you have gone a year without a menstrual cycle, a period. So there's perimenopause, and then the menopause is the event, and then there's everything after it. Perimenopause has historically not been talked about a lot. So women have been left to sort of figure it out as they go. Even today, women are starting to talk more to each other about these things. Healthcare providers are starting to consider some of these things, but there's a lot of your labs look normal, and kind of, you're too young to be experiencing this. Lots of being dismissed and not considering how this stage of life can affect all of the other health issues that you're dealing with. We also know that with perimenopause, the symptoms that women experience in early perimenopause are different than those that are experienced later, because the hormonal shifts that happen are different. So early on, you're experiencing these shifts in progesterone, which are more likely to kind of soften mood. And so, you may be dealing with more irritability. People often report conflict with their partners during, earlier periods of perimenopause. And if you're relying on your partner for support and partnership to manage some of your symptoms, maybe you actually have been able to work out an equitable partnership to where you can do the things that you need to do because you're not having to do all of the things. But now you're shifting and you're thinking about things differently, and maybe your mood is shifting and there's more conflict. This time period also can come with more fatigue added to things. And a major symptom of perimenopause that people have described as the most disruptive in their lives is brain fog. So maybe you're already dealing with brain fog from hypersomnia, and then you have to layer on these other things, because while you are a person with hypersomnia, you're also a woman experiencing perimenopause. And so life doesn't stop because you have a chronic condition. And as you move through that, then there's more of the estrogen related symptoms. Estrogen and testosterone tend to be more affected later in perimenopause, and you're dealing with hot flashes and insomnia. So maybe you're sleepy all the time, but you can't sleep at night. You're physically uncomfortable. It's waking you up. All of this added stress can exacerbate symptoms of sleepiness and brain fog and things like that. So as you can see, there are kind of constant new challenges for women in general. And when you layer on top of it one or more chronic conditions, especially a hypersomnia diagnosis, then that just complicates things. So you may think you found something that works, but you're constantly having to adjust your strategies. Okay. So let's talk a little bit about women in general in society. We know that women are more likely to be caregivers. Specifically in like informal caregiving settings, not just as, motherhood and being a parent and caring for children. Women are more likely to be caregivers to loved ones or family members. And the midlife period is where women are considered kind of part of the sandwich generation, where you're both trying to raise your own children and take care of aging parents. So right now we're looking at kind of like maybe later Gen Z, maybe into this period, and, kind of earlier Gen X. So it spans this period of time of women all at, kind of differing stages of life, but they're sandwiched in there and they're expected to take care of a lot of people. In our society here, we don't really have a great safety net for caring for our elderly. There's a lot of struggles that people experience. Sometimes it can be a very fulfilling experience to care for one's aging parents. Maybe that's something you want to do, but good stress, positive stress is still stress, and your body experiences that in the same way. Women who are caregivers are at a greater risk for severe stress, adjustment disorders. So, those kind of time periods in life and being able to move through them smoothly and adjust to them. Depression, anxiety, sleep disorders, diseases of the spine and back, so like back pain, other pain conditions, and just in general, a lower quality of life. So you're throwing all of yourself into people that you love and care about. It may be something you don't want to have to do. It may be something that you do want to do, but you are still at a greater risk of all of these things. And all of these things will make it more difficult to fulfill those roles and make it more difficult to enjoy your own life while you're taking care of everyone else. Let's look at this graph. Now, this is a little bit older. It goes up until 2011, but there's lots in pop psychology and pop media discussion about how this kind of new generation of parents, millennial parents, which I guess we're not the young ones anymore. I'm on the older end of that side. Tend to be spending more time with their children, even though they're more likely to have, dual incomes, two parents working full time. They are spending more time with their children than previous generations. When you look at mothers versus fathers, fathers are definitely, between 1965 and 2011, they've doubled the amount of time that they've been spending on housework and childcare. So that's great. We're moving in the right direction. But their paid work has not really decreased that much proportionally. So there's been some reduction in the amount of time that they spend on paid work, but not as much as has been added with childcare and housework. So fathers are exhausted. We will acknowledge that too. Mothers, though, and gotta move the gallery there. Mothers have increased the amount of time they're spending on paid work, more than doubled that. Their housework has gone down a little bit, but that's been taken over by paid work. And the amount of time they spend on housework is still about double what fathers spend. And the amount of time that they spend on childcare has increased. So they're still, while their time with their children has increased, and their time with their children is still double that, almost double that of what fathers do. So quite literally, in a day, you're trying to squeeze more in, and you don't get extra hours. And the saying, oh, we all have the same, 24 hours in a day, that doesn't actually apply when you're talking about chronic illness, and particularly hypersomnia, because there are hours in the day that you're having to give over to managing these things, sleeping, taking naps. If you experience long sleep duration, that's taking away time in your day. You have fewer hours. And a lot of those expectations from the world around you don't change just because you have that. So there's a greater demand on your resources when you're experiencing hypersomnia. What's interesting about the work, the kind of domestic labor, is that while women are still responsible or considered responsible for more of the kind of domestic labor in general, the part that has been identified as causing the greatest distress in that dynamic is the cognitive labor. And that was shown to be particularly gendered. So men in relationships do tend to be more involved than historically they were in terms of the physical labor of taking care of the house. But the cognitive labor of planning it and noticing when it needs to be done and making the list and keeping track of when doctor's appointments are and everybody's schedule and holding all of the information of the family in your brain and problem solving, that still tends to lie with mothers. They tend to be the default parent, and that is more so than doing the laundry and changing the diapers. The cognitive labor is what contributes the most to their overall distress. Okay. These are the chart and the text are from two different studies, but they both get at the same thing. Everybody's tired, and people with IH or narcolepsy are sleepy. So everybody's already tired. There's just this baseline exhaustion that most of us are experiencing in life, even with our healthy counterparts, but women more so. So you can see in the chart there to the right, it says, we're mostly exhausted. Yes, men endorse feeling stressed or nervous, and feeling exhausted in the past month. Women even more so. And this is within the general population. Add sleepiness on top of the exhaustion, add predisposition to stress, depression, anxiety. This is just a compounding factor for people with IH and other chronic conditions. Women in a healthy sample or general population sample are also more likely to say that sleepiness affects their daily activities to some extent. They had a rating scale. So they were more likely to endorse some effect of sleepiness on their activities. And this was in a recent study by the American Academy of Sleep Medicine. So these are really up-to-date numbers. Okay, now I want to read something to you here. Let me pull up my notes rather than having it on the screen because I hate when people do that. You may be familiar with someone, author, sociologist, or no, she's a social worker, licensed clinical social worker and researcher, Brene Brown. Her book, Daring Greatly, she writes, when I asked women to share their definitions or experiences of shame, here's what I heard. Look perfect, do perfect, be perfect. Anything less than that is shaming. Being judged by other mothers, being exposed, the flawed parts of yourself that you want to hide from everyone are revealed. No matter what I achieve or how far I've come, where I come from, and what I've survived will always keep me from feeling like I'm good enough. Even though everyone knows that there's no way to do it all, everyone still expects it. Shame is when you can't pull off looking like it's under control. Never enough at home, never enough at work, never enough in bed, never enough with my parents. Shame is never enough. No seat at the cool table. The pretty girls are laughing. And this is what she kind of describes as the experience of women in modern society. And so if you think about all of these contradictions, people acknowledging that things are impossible to achieve these goals and yet still expecting it. And these types of expectations have been internalized by women. So it's not just that they're feeling that pressure from outside of themselves, but women put this pressure on themselves. And there's been a lot more attention, especially because people are writing about it in this way and talking about it more to challenge these things. But it remains. And that is a cultural phenomenon of gender roles that will take a very long time to dismantle if it's going to happen. She goes on to discuss that there are competing and conflicting expectations with the way that people interact with women. So it says, be perfect, but don't make a fuss about it. And don't take time away from anything like your family or your partner or your work. If you're really good, perfection should be easy. Don't upset anyone or hurt anyone's feelings, but say what's on your mind. Don't make people uncomfortable, but be honest. Don't get too emotional, but don't be too detached either. These are all things that when you have a chronic condition and you're having to discuss boundaries, discuss expectations in your home, fight for accommodations at work or school, women are also layering on these contradictory expectations. You're expected to set the boundaries. If you don't set boundaries, then that's a problem that you need to address. You're not good at setting boundaries. But if you go and express a boundary at work, like when I clock out, I have to be done. I'm managing a chronic medical condition. That can be seen as not part of the team or, too aggressive. So these are just, while probably everyone deals with this to some extent, women in particular are saddled with these contradictions, and it adds to the cognitive labor. So I want to show you kind of my thought process in planning this presentation when I was invited to do it. Well, actually, no, let's go back. Sorry. um, let's talk a little bit about clinical trials. So women make up about half of the population. They were not required to be included in clinical trials until 1993. Even then, in 1993, there was very low enrollment. So it wasn't that women were required to be, proportionally included in clinical trials. It just, there had to be some there. So they were still not well represented in research until now, and still not where it needs to be. At present, or I guess in 2021, 22% of phase 1 trials patients were women. And it's half the population. So that's not giving the same safety data. It's not giving the same efficacy data. It's not giving the same, side effects that you might experience. So women have less information to go on when making medical decisions about their treatments. In 2022, there was another large-scale trial looking at, I believe, over 300,000 patients, and the percentage of female participants in clinical trials at that point was 41.2%, which is getting there. But this was after having to add on to the law that required their inclusion, action plans for recruiting women, because there are still not being enrolled in the same numbers. So you're having to actively recruit women for these clinical trials. Okay. So I mentioned earlier that we would go over some of these complex medication decisions that women have to contend with. So these interactions include like psychiatric medications that you may be taking for one of these mental health conditions that you're struggling with. They can interact with sleep. So things like antidepressants, tricyclic antidepressants, SSRIs, as well as definitely some antipsychotic medications, which, yes, are used for psychotic disorders, but are also often used with bipolar disorder or as kind of to boost the effect of other antidepressants. They can be very sedating, definitely treatments for bipolar disorder. Mood stabilizers can be very sedating. There are anxiolytics. So we're talking about like benzodiazepines, buspirone, hydroxyzine. These are things that are used for like acute anxiety management that can be very sedating. Even some anticonvulsant medications are used for mental health diagnoses for treatment. So like topiramate, which is used for eating disorders and substance use disorders, valproic acid, which is used to treat manic episodes with bipolar disorder. These are all things that can exacerbate the sleepiness and also other factors that you're dealing with hypersomnia, like brain fog and things like that. Then you can look at it in the reverse. There are hypersomnia medications that can affect which psychiatric conditions you're experiencing. So, for example, we wouldn't recommend that somebody with anxiety be taking stimulants necessarily. And so that's a condition or a consideration that you have to make. It's not necessarily always a bad thing, but you have to monitor that. It's a special consideration. The oxybates can, at the wrong dose as you're titrating, can lead to depressive symptoms. They can lead to brain fog, things like that. So that has to be addressed and monitored in titration and if symptoms change over time. And then you look at IH and psychiatric medications, both of them, and they can affect hormones. So we mentioned earlier that some medications can affect the efficacy of contraception. So those are the uh, goodness, modafinils and armodafinil, and they don't necessarily preclude using contraceptions, but that's a special consideration that has to be taken. They can also affect how quickly exogenous hormones are metabolized. So if folks are using hormone therapy in perimenopause and postmenopause, then you have to take that into consideration as well. So you look at these things, the reproductive lifespan of a woman, the societal expectations, the internal expectations, the increased risk of mental health disorders, which can come from any chronic condition, which can come from hypersomnias, which can come from the added stress of being a woman who is a caregiver, or just trying to exist in the world today, carrying the mental load. They can all affect each other. And it's very difficult, dare I say, impossible to really pull out which is responsible for which symptom because they're likely all contributing. So this is what my thought process was when I was building this presentation. So I started out, I was like, okay, let's just like get all of this out of my head and try to figure it out. You don't have to try to read all of this. I work in Venn diagrams and I was like, okay, how do they intersect? What are we putting here? And it just got so messy that I thought, well, this is not helpful at all. So I had to come up with a new approach. But the gist of what I want to kind of leave you all with is that we need to pay more attention to what women are experiencing. There needs to be more research, of course, and women have to cut themselves a little slack, ask for help, set boundaries, even if it's hard. These are things that a lot of us are actively working on all the time. I'm a psychologist, but I'm not perfect at these things either. And so it takes constant evaluation, and that is additional cognitive work as well. So, I hope that this was not too much of a downer to look at all of the unique challenges, but I think it highlights what is yet to be done and what needs to be done in working with women with hypersomnia.
Thank you, Anna. That was really profound and meaningful, and I think that Venn diagram at the end there pretty much says it all. Yeah, there's a lot to process and think there. And again, we were asked, is it recorded? Yes, we'll be putting it on the YouTube channel and the website. We'll be announcing the video presentations being available in the next week or so. We have time for a couple of questions, Anna. So the first one is, do you have any thoughts on the burden young women being the primary family member that seeks medical diagnosis and care? For example, I have IH and endometriosis, and I'm fairly sure I have family members with one or both of these disorders.
So is the question asking like thoughts about encouraging family members to also seek out evaluation and diagnosis?
Actually, I think it says, the first bit says, do you have any thoughts on the burden of young women in particular? Because they're the primary family member that seek. I think you said earlier on that women are doing, men might be doing a bit more diaper changes, big whoop, but also that they're not carrying the cognitive burden. And I think it probably is speaking to that.
Oh, sure, absolutely. That actually highlights a part of the cognitive load that that I didn't mention, which is simply paying attention. So, noticing the people around you and thinking about them, whether it's a social construct or something inherent, I would say it's probably a little bit more nurture in this case, but women are just more interpersonally aware a lot of the times. Not all, like it's a generalization, I know, but in the case of this conversation, it is true. They tend to be more aware of the people around them because they're more responsible for them as a caregiver. And so if you're noticing your own symptoms, And then you see them in others as you learn about where these symptoms come from, that they are in fact symptoms and not just, I guess everybody deals with this. Educating your family members, advocating for them, going with your parents to their doctor's appointment to explain it because your parents don't quite get it. Um, I would even say flipping that in the other direction. A lot of times parents, or not the older generation here, but like young women, in their kind of family period, may realize that they are having symptoms because they see it in their children. And so that also can be kind of a wake up period as well, because women tend to kind of put their own needs and their own complaints on the back burner. And I don't have time for that. So, I won't think about it. I can't squeeze in my own doctor's appointment. But when it comes to your kids, you make the time, you make it happen. And once you start seeing their challenges, and it's very much a mirror of yourself, then that can be pretty profound experience.
Right, and I think with the demands that you've outlined there that women are under, of course you're tired. There's a
Yes.
misdiagnosis right there, potentially.
Yeah. And it's
Okay.
hard to parse out, hypersomnia isn't just being tired, right? Like it's this whole other experience. And in like health psychology and sleep medicine, you always have to educate people on the difference between being tired and being sleepy. And so in this case, it's all of the above.
Yeah, here's a heartfelt sort of response to that. It says both from an anonymous attendee, both the cognitive load as well as trying to convince family members who don't seek a diagnosis that I therefore often feel guilty that I do have a diagnosis and a treatment plan and my siblings or parents don't. And there's another layer, guilt.
hmm I was going to say the same thing, which is it can be very difficult for women, particularly when you kind of see yourself as the caregiver or just love somebody and see them struggling, to let go of that and to, let people make their own decisions, even if they're maybe not the healthiest. And that's a really big challenge for a lot of people.
Yeah, I think listening to your whole presentation and sort of wanting to push pause on some of it and process it a bit more, because I think if we acknowledge what you've said, because those aspects relate, and for the record, I don't have a sleep disorder, my daughter does, so I'm more of a caregiver in this context. But I think that's the first step, isn't it? In being able to name it, label it,
Mhm.
acknowledge it, and then be able to move forward with all the various challenges that we're under. And
Yeah.
yeah, I just want to thank you. I think we'll be repurposing this video again. It is recorded and it'll be put out. Um, so I'd like to thank you, Anna. I think we're out of time, actually.
I'm sorry I went over. I'm
No,
happy
not
to
at
answer
all.
questions, or if anybody wants,
Yeah. Well,
I
let's try
have
and squeeze in.
I have recitations if people wanted, or things like that.
Yeah, thank you. Let's squeeze in one more. Medical appointments are scheduled very far out, and things come up when you have kids. It talks to the juggling and the planning, doesn't it?
Yes, absolutely. Not only do you have to plan very far out for things, like, for example, my kids have been enrolled for summer camp already for over a month, right? Like, you have to keep track of these things. This is the cognitive load, right? You don't have to have hypersomnia to be stressed out about, can you get your kids into summer camp and things like that. But when you're dealing with brain fog and sleepiness, that just makes it that much harder. But then let's say you plan all that far out, you get to summer camp, and then all of a sudden, I don't know, everybody gets sick, and now you have to deal with that. So not only is it an expectation that you be very good at planning and, kind of looking ahead and being prepared for the future, you also have to be constantly prepared
Pivot.
that all of those plans might go out the window.
Yeah. Yeah.
um, and that can keep you in this kind of survival state
Yeah.
where you can't really relax because something could change at any minute.
Yeah, that's hard because you think you've done a great job in the planning, but life always throws a bit of a curveball, and that you don't have the spoons for it. And all the
Exactly.
on top of everything else. I mean, the comments here, Anna, and speaking here from LA with our wonderful team on the back end here. Our phone's been blowing up all morning with how helpful this has been, but in particular, I think there are some shout outs to you for
Oh, thank you.
really a presentation and a speech that's been very validating. Tremendous million thanks.
Oh,
There's more.
well, I would like to say thank you to everyone for being here. This has been a journey for me as well, and I'm still figuring it out. And so, if it can be validating at all that I'm a psychologist and I'm not sure how to handle all of this, life is challenging sometimes, and even when you don't have spoons, when things need to be done, you just I can't explain how we do it, but we manage it.
Thank you. One passing comment before we tie up is this was very helpful, but also the legitimization of the hell I'm going through. This is very helpful. And I think, thank you for you being on the journey with us, but also it is validating hearing from someone who has IH, but is also a psychologist, and a parent, and navigating all the things and sort of owning that you don't necessarily have all the answers, but this has been incredibly helpful. So on behalf of our speakers and Hypersomnia Foundation, thank you everyone for attending. It's been a delight, and we'll see you soon. Thank you everyone. Bye, Anna.